Hello, and welcome to the Surgical Assistant Podcast, a podcast crafted by surgical assistants for surgical assistants, where professionalism meets passion. Hi, everybody. Welcome back to the Surgical Assistant Podcast. I'm John, and with me, as always, Kelly.
Hello, everyone.
Hey, Kelly. And tonight we have a special guest, Dr. Karishma Reddy. She's a plastic surgeon I worked with in Virginia, and probably one of the better plastic surgeons I've worked with in my entire career. Dr. Reddy did her undergrad at University of Miami, and you did medical school at the Medical College of Georgia, correct?
That's right.
And
Yep.
then you had your plastic surgery residency. You did an integrated plastic surgery residency at UNC Chapel Hill.
Yep. Go
where
heal.
You got the Keith Amos Excellence in Breast Surgery Award there, didn't you?
Yes. Yeah.
That's
Breast has
wonderful.
always been a huge focus for me all the way from the start of the training through in now in my career. Breast is a huge part of what I do. And thank you guys so much for having me. I appreciate it.
We appreciate
you're welcome.
you.
It's
Thanks
our
for being
pleasure.
here.
Thank you so much. Sorry it took so long to get us together, but we just wanted to talk a little bit about cosmetic breast surgery because this is the third and final part in our series on breast surgery. We did cancer of the breast, then we did post-mastectomy reconstruction. Now we're doing cosmetic surgery. So we're kind of going to focus on just a few types of breast surgery, the reduction mammoplasty, and then the augmentation mammoplasty, and then we'll kind of go from there. But
Sure.
when you do a reduction mammoplasty, can you maybe just talk a little bit about the indications and then which incision you prefer? I mean, I know there's a lollipop and then inverted T, and if you can just talk a little bit about that, that would be great.
Yeah. So actually in the realm of plastic surgery, when we go through patient satisfaction scores, reductions for breast reductions are going to be our highest scoring surgery in all of the realm of plastic surgery. And that's because reductions really address patient suffering functionally, and they also aesthetically benefit somebody. So you've got a twofold, really powerful surgery that can really change a woman's life. And for people who are good candidates for reductions, these are going to be women whose breasts are just too large for their body frames. And truly, when the breast isn't sitting on the chest wall where it should, and it's hanging too far down, that creates a lot of pounds of pressure and traction on neck, shoulders, upper backs. And so when we do a reduction mammoplasty, the goals are to really make that breast a narrower, rounder, smaller breast that is now going to be seated on the chest wall instead of hanging several inches down. And we want to make that patient way more proportional and also alleviate a lot of the pressure and pain they're feeling on their backs and necks. So a good patient for that is just anybody who feels like their breasts are not in proportion with their own body size and desire a lighter, perkier breast. I always get questions from patients like, I want a breast reduction, but is there any way I can get a lift built into that too? That's a common misconception. Anytime we're going to do a reduction, automatically we are lifting the breast at the same time. So people don't have to worry about adding an extra surgery. A reduction will, by definition, lift a breast and reduce its volume.
Are they typically covered by insurance, those cases?
That's a good question. So insurance companies will cover a breast reduction, but by typical insurance standards, they're going to make this as painful as possible for their patients. So they're going to make you jump through a couple different hoops. They want a long documented history of back, neck, shoulder pain. They want a history of rashes under the breast. And then they also want you to fail physical therapy ×3 before they're going to let you get approved to have a reduction. And we know that physical therapy exercises aren't going to make your breast smaller. So we already know that that's not going to work. But why not waste your time a little bit longer?
Exactly.
One of the things I really oppose as a surgeon is that insurance companies, they use an equation to tell surgeons how much weight to take off in a breast reduction. And the two variables they calculate in are going to be a patient's height and weight. And breasts don't really vary by height. But crazily enough, like my really tall patients would need more taken off in a reduction in order for insurance to cover it, which makes little to no sense. Yeah. So if you are a surgical assist and you are doing an insurance-based reduction, we'll constantly, as we're taking tissue off, we're having them weigh it and we're paying attention to the number because we need to hit a certain number to make sure that an insurance company will pay for the surgery on the other end of it. But that's a huge
Okay.
reason why I've kind of backed away from insurance-based reductions, because operatively,
Mhm.
we're trying to focus on an aesthetic that the patient and me have decided on together, and their height and weight don't really play into that. We're trying to hit a goal for a patient that what looks good on her body. I don't want to over reduce or under reduce her just so that we can get a procedure paid for.
Right.
I see your point. And I definitely have, in my experience, those patients come in and they are so happy to have that done. And I mean, you
Yeah.
can literally see the grooves in their shoulder from the years of just the weight of their bra and everything. When you do these procedures, is the type of incision like the circumareolar or the inverted T, or I mean, is that dependent on the patient, or is that just a preferential technique that you like to use?
So a lot of surgeons, if we can get away with a lollipop, what's going to be the perioreolar and just a vertical line,
Hmm.
that's nice in terms of we're not compromising blood supply. Anytime you make the vertical and the horizontal, where those two lines meet, we're very high risk for a wound because the blood supply has been cut in two different ways. So if a surgeon can get away with a lollipop, then we're only really compromising the flap one way so that they'll have less wound healing issues. The problem is when you're reducing a breast, you have to think we want to reduce it side to side, so that's going to be that vertical incision. We also
Hmm.
want to lift the breast significantly, and that's usually that up and down, and that's going to be the horizontal incision. So a lot of my patients who do have larger breasts, almost all of them are going to need that anchor that we can
Hmm.
address the breast three-dimensionally and make sure that we downsize it in both dimensions. But for
Okay.
surgical assist, anytime I'm having a essay close with me, I always tell them to pay really close attention when those two lines meet. That
Hmm.
T junction is going to be the highest risk of a wound. So I always tell them with pickups, be really, really careful about that tissue. Don't manhandle it. Be
Hmm.
really respectful to the blood supply and the dermis and get a really solid closure there, because that's where you're going to be the highest risk for a wound.
Okay. And so I guess we can just talk a little bit about that. So do you have what are your caveats when you're doing these reduction mammoplasties? Like with patient position, you typically secure the arms with Curlex because you'll be sitting on the up to check the symmetry. You use, do you use any kind of patient warming under the patient, like a hot dog or a fluid warmer?
We always try to do an underbody fluid warmer. That's always nice. If we can keep the patient's temperature as stabilized as possible, that's always great for them.
Hmm.
And yes, definitely I always keep my arms out, because for me in a reduction, it's a three-dimensional surgery. Breasts look very different laying down than they do sitting
Hmm.
up. And one of the really important things that we're trying to get is that we want those nipples to be at the same exact level. And the only way you're going to know that is if you sit that patient up in the OR. You want to always check shoulders.
Hmm.
And that's how we're going to make those spinal approximations. So having an eye for that is really important, because we do sit up quite a bit.
Wonderful. Kelly, you have anything you want to add or any questions?
I was just going to ask, I may be getting ahead, but I was going to ask, do you have a preference? Do these have to be done in a hospital, or do you do these in an outpatient facility?
I find these are very safe surgeries to do outpatient. The surgery takes me about 2 to 2.5 hours, and so I think it's very safe. I do a drain-less breast reduction. I think cutting the drains out of it has been very helpful in progressing the patient post-operative course. Carrying long drains with bulbs around for a week or two at a time is psychologically a lot and also physically a lot. So making a couple of different maneuvers to modernize the surgery, I think it's very safe to do in an outpatient surgery center.
Okay. And does the lack of drain, the overnight stay less, is that the primary factor, I guess is what I'm asking, in keeping a patient overnight after one of these, or?
I think so. I think it's pretty, like in 2025, keeping someone overnight for just a breast reduction, I think is very, very conservative. Unless
Yeah.
that patient has significant medical problems, I think
Right.
it's okay. But some surgeons do prefer to put a drain in and then the next morning pull it. So for convenience, we'll hospitalize the patient. But
Okay.
now as we think about like the cost of healthcare and everything, and the shortage of bed, we're really all trying to make steps forward to make this as friendly as possible to get patients home. And then I always see my patients the next day in clinic. I want to check nipple perfusion to make sure the nipples look fine. That's one of the big things. And the second thing you always want to look for is that the breasts don't have a hematoma. So any signs that one breast is way more swollen and bruised, those are the two reasons I want to see my patient within 24 hours of doing a reduction if I can.
Okay. Yep.
Any caveats with your dressings for your reduction mammoplasties? How do you typically dress those?
I was doing Durabond my first year in practice, and then, as I came to realize about 20 to 30% of our population is having really adverse reactions to Durabond. And when they do, those reactions can be pretty significant, like really,
Mm,
really bad rashes, skin irritation, sloughing. So I backed Durabond out of this situation, and I really tend to just do steri strips and then fluffs in a surgical bra. And then those steri strips are going to come off within like 7 to 10 days because sometimes they can hold some moisture around wounds, and we don't want that.
mm.
Um, but I that's usually been my go-to dressing.
How about, do you use any negative pressure wound dressings for your reduction mammoplasties? Like a
I
Pico or a Provena?
I would love, like, especially I think in the higher risk patients where if your BMI is over 35 or we're doing like a pretty significant reduction, I think the Provena or the Pico really does do a lot to put that against a dressing. Those dressings are very expensive, I think around $1,000 to $2,000. So, you want to use them sparingly, and I do, but I do think those are very helpful in the right case, especially someone who's high risk for wound healing issues.
Okay. That
Great,
makes sense. Yeah.
thanks. So we'll move on to augmentation mammoplasties then. So let's see. I guess we can start off with talking about the Motiva implant. That's the most exciting. I know you and I had an interview once, not too long ago. Well, it's about a year ago now, where we talked about the Motiva implant. But I was hoping to fold it into this podcast, so I kind of waited on editing it. So, are
Um,
you now exclusively using the Motiva implants for all your patients, or is it just a tool in your toolbox?
It's funny because, like, so silicone implants for a long time, we were stuck at the 5th generation. We hadn't seen a lot technology or science or any kind of implementation in the implant world because the US FDA is very, very strict on devices. It takes an incredible amount of time and endurance to get an implant approved by FDA. So Motiva has been around in the world. So they're using it a bunch in South America,
Mhm.
in Asia and Europe. So we have 10 years of data on Motiva, but we just saw their entrance into the US market in fall. And as a surgeon, I'm very mistrusting of any kind of new device. I do my due diligence, but I really do think Motiva rebuilt the implant from the ground up. And the couple of the things that I really like about them, one, their capsular contracture rate is less than 1%, and their gel rupture and gel leak risk is less than 1%. And our
Oh.
5th generation device is at 10 years. The CapCon risk was 10%. So we have
Oh.
significantly come down. And one of the big things that we were talking about, I think now everyone is talking about, is like inflammation in the body. Anything that
Mhm.
can mimic human tissue and not cause a huge body inflammation reaction is seeing an uptrend. In Motiva's surface is basically built to mimic the same surface as a human cell. And so we're seeing very minimal implant reaction, very minimal inflammation, which I think women are very interested in today's day and age.
Mm.
And just the safety profiles of the implants, I think, are really what attracts me a lot to Motiva. And to answer your question, so I present
Mhm.
5th and 6th generation implants to my patients, and we price everything out for them. But I have seen almost 100% of my patients switch over when they really get to know the data behind the devices, they do their research. And the cost differential is pretty minimal. But when you think about a device that's going to be in you for 10 to 20 plus years, then I
Mm.
think, $100 or $150, that speaks less to it.
I see. So, when you approach an augmentation mammoplasty for the patient, how do you balance their expectations with the reality of the surgery? Do patients have sometimes an unrealistic expectation of what they want to expect out of their breast surgery, or?
But I do think, like, because of social media, we're seeing such a, like, inundation of women's breasts. So I
Mhm.
do think it's really important to try to establish as realistically as you can what their before and after is gonna look like. The 2 biggest things I see is women will come in and say, "I really wanna make sure my breasts don't have a gap in the middle. I wanna make sure they sit right next to each other." And truly, that's a little bit anatomically limited. So our
Mm.
breastbone sits between our cleavage. You don't wanna over dissect onto the sternum because that can risk you for what's called uniboob or synmasthia. And so
Cinemastia.
That's a very, very difficult problem to correct. So we always respect the borders of the sternum. And some women do have a really wide sternum. And I think those women, it's really important for me to sit down with them and point out the differences between their wish pictures and their anatomy, make sure they understand we don't want to change that width because that's something we can't really unmess up, to say it in
Right.
a censored way. So that's one thing. The second thing is that in the Ozempic era, we're seeing women with a lot of rapid weight loss. We're
Mhm.
seeing women with breast deflational changes. And also I see a lot of women who've had children. And sometimes there is a little bit of a surprise factor when they realize, like, to get the look they want, they probably will need a lift. A lot of women are very averse to a lift. They don't want any scars on their breasts. But truly, I have found in my career that if you bypass the lift and try to tell them, we'll upsize the implant to make up for it, it's never going to be a good idea because
Mm.
an implant is making up for breast volume. The lift is really taking your breast from where it's sagging and putting it back on the centralized portion of your chest. And to try to fix one problem with another is never a good idea. But I will say a lot of my earlier predecessors of surgeons, you'll see a lot of women who are told, upsize your implant and then we can kind of bypass the lift. And in 1 to 2 years, I see them back and they're not happy with where their breast tissue is sitting.
Okay, thank you.
And let
And
me,
what
I'm sorry, John, can I interrupt
No,
right
go right
there? Because
ahead.
just along those lines, conversely, or really, I think I hear what you're saying is if you have a patient that says, well, I'm happy with the size of my breast, I just want them lifted. Are you going to tell them as well, it's better to put a little bit of an implant in there? Because is that true that tissue, if you only did a lift without adding some kind of augmentation, and I'm talking about obviously in a woman that doesn't need a reduction.
Right.
She just wants her breasts lifted. Would you say that is true for that as well, that scenario, that they
That's a
would
good
need?
question. I am very clear, like, I think a big misinterpretation. So a natural human breast, all natural human breasts have a little bit of a slope. It's a little bit of a concavity above the breast. And in society, we're so used to seeing a very loud upper pull, a lot of fullness in the upper cleavage.
Right.
And I tell all of my patients, if you see a loud upper pull, that's not a natural breast. That is usually an implant. So if that's what you're looking for, you can't just achieve that with just a lift. If you're okay with a little bit of that slope and you just want to lift your breast, then you're a great candidate for a breast lift. But you
Okay.
have to make that clear because the patients don't understand the difference between the two.
Yes. Okay. Right.
So when it comes to doing the actual surgery, how do you make the decision for the incision, whether it's a circumareolar or an inframammary incision? Is it, patient specific, or do you just have one that you like to do every time?
So, like, as an implant surgeon, one of the biggest things we want to reduce our risk for is capsular contracture. And so, capsular contracture is basically if the body senses that that implant has some kind of biofilm or some kind of even very subtle bacteria associated with it, the body's natural response is to start building a really thick shell around that implant. And that can start causing pain and disfigurement. So, we actually have a lot of technical ways that we can reduce somebody's risk of that. And there's a couple different things that go into that. So when we're placing an implant, the no touch technique, so we really don't want to be touching physically our implants. We really want to try to go right from the box into a Keller funnel or into the funnel and then use the incision and place the implant in. So I always tell my SAs when we're doing any kind of implant case, I'm very, very psychotic about sterile technique. So right before I place an implant, I'll change my glove, and then we're doing a no-touch technique from implant to funnel into the body because we really don't want to associate that implant with any bacteria. As far as an incision goes, so the 3 traditional incisions that we used to place implants through was 1 in the armpit, 2 periareolar, like right by your areola, and then the 3rd was under the breast fold. And we know that the armpit is associated with a lot of bacteria. Also, very difficult dissection to get right when you're coming from such a limited view.
Mm.
And then we know that the nipple is associated with a lot of bacteria because the milk ducts. So those 2 approaches I don't use at all because we know that they're associated with higher capsular contracture rates. So I think those are very quickly becoming a thing of the past. the safest way to approach the breast from an implant perspective is going to be through the fold. There is no high traffic of bacteria through that incision. And it's a good pocket where you can really see the breast from medial to lateral and get a good customized pocket for that implant and not have high traffic bacteria. So I'm always going to use that fold incision to put an implant in.
Okay, and that brings up another question then. Do you place the implants underneath the pectoralis muscle or above it? And do you use any kind of acellular dermal matrix with a regular augmentation?
So almost all my augments, I don't think a primary augmentation needs a mesh of any sort. There are a couple caveats. So I used to be 100% under the muscle because we knew that when you went above the muscle, like in the subglandular field, that the rate of capsular contracture was up to 30%. So because there was a very direct traffic from nipple ducts to implant, that's why the capcon rate was so high. Now, a lot of us have started a new plane called the subfascial plane. So we're above the muscle, but we're under the pec fascia. And that fascia is giving you a nice security blanket away from the breast gland, away from interface with the milk duct, but it is muscle sparing. So that and combination with Motiva implants, I am offering a lot more above the muscle augmentations. I will tell my patients who are smaller breasted, you're going to have a much more louder or more obnoxious augmentation because the pec isn't there to kind of dampen down that upper pull. You're going to go straight from chest wall to implant. So if you don't have a little bit of your own breast tissue to camouflage that transition, it'll be a little louder for you. So they have to be okay with that. And also I find that my patients who are very like physically into chest press, bench press, anything that's going to constantly activate the pec, when your pec is there and the implant is here, you're going to constantly encourage your implant to go down and out. So if they're telling me, look, I'm going to be back at the gym in a few weeks, or these are the exercises I'm really committed to, and I'm not willing to change that, those are people I'm going to start considering going above their muscle so we're not risking implant displacement over time.
Oh, great.
Okay,
Thank you.
yeah.
Kelly, you have anything you want to add? Any questions?
No.
Is there ever any?
That's going to clear up a lot of questions. Now, for those of us that don't do plastic surgery on the regular, I mean, I think I've done more breast reductions than augmentations. So
Yeah.
even I, as a first assistant for 13 years, I haven't done a ton of these. So that just is answering some really good questions for us. Yeah.
Yeah. I
Yeah.
think like the most, if I can convey anything, especially to surgical assistants who are listening to this podcast, is just we truly have, it's very pivotal. The technique is so important when it comes to implant. And so every single person in the OR has to respect that. And you have to think about it every single time. Like even when we're doing the closing layer, if you're going to throw a light retractor back in that pocket, you technically can risk contamination. So you have to really rethink the level of sterility one more time. Anytime you're dealing with a forward body, whether if it's a joint replacement, implants, that's when surgeons get really uptight and crazy because a little bit of lackadaisical behavior in the OR, the patient's going to go through a lot more.
So I know you mentioned in reference to that, then I know you mentioned the no-touch technique and using a Keller funnel. What other safeguards do you use? Do you use a lot of antibiotic irrigation? Do you,
So before I start the case, I usually do a betadine prep. And then before I start, I'm going to do a chlorhexidine prep of just the nipple and areola. Because again, we know that the nipple is associated with a lot of bacteria. So that's going to get a chlorhexidine prep and then a tegaderm over the nipple. And I don't take that off until my final layers are closed, just so we can do one more step to dissociate from the nipple and areola. And then the pocket, once I'm done fully dissecting it, we're going to do a betadine wash and then a triple antibiotic. And then the one thing you always want to make sure is that there isn't any blood in the pocket. Any small amount of blood triggers the body to think about inflammation and attracts bacteria as well. So you really want to make sure you get a good washout. You don't want any stagnant blood. You want any potential vessels that are going to go off later. So those are all important things that we pay attention to. And then change your gloves, the Keller funnel. I irrigate my implant in the box. I put an 18 gauge with a 20 cc syringe and put a little bit of antibiotic irrigation. Because we did have a study that showed when you peeled off that protective layer without putting any kind of irrigation first, it was actually a negative feel and creating like a vacuum to dust in the room, which sounds crazy. So I break that seal with an 18 gauge and some antibiotic irrigation so that when we peel it off, we're not trying to create a negative seal that creates particulates into the box, into the implant.
Oh, great. Thank you. And how about your dressings for your post-augmentation mammoplasters? I know you said you got away from Dermabond, so you don't use Prineo or anything for your incisions?
I would love to because I have seen some of my I have seen some patients from other surgeons who have Prineo and it looks very pretty in the right person, but I still have a little bit of Dermabond PTSD, so I'm just gonna do steri strips along my incision and then a surgical bra and fluff, and that's all I usually do for my augs too. But I
Yeah.
do, I do think that Prineo does do a nice job in the right patient.
Wonderful. And let's see, Kelly, do you have any questions or about in relation to the augmentation
Um,
mammoplasties or?
yeah, I was going to ask. Actually, I was speaking to someone at work today about this interview, and she mentioned this. So I said, "Oh, that would be a good question to ask. Is there any minimum size that you talk about with your patients that want augmentations?"
Yeah, I think actually I feel like we do a disservice to patients. I think breast implant sizing is actually very convoluted and very complex. And now with social media, there's so much information that patients can get very, very confused about sizing. And it's always an addition equation. So like Kylie Jenner released her stats for her breast augmentation and patients went crazy and were like, I want her breast, so I want this number of cc's. And that's definitely not how breast augmentation works. So you always have to think about when you're looking at before and afters, you have to make sure you're finding befores that reflect your own breast tissue growth. So that's one thing that's really important. And the second thing is that plastic surgeons are really actually thinking about one measurement way more. It's called the breast width. And that breast width of your footprint of your breast is actually really important when we're sizing implants. We don't want an implant that's way wider than your breast footprint or narrower. And so when I'm trying implants on patients, I'm always trying to figure out, I'll actually put them in a tank top and put sizers in under the tank top, but I'm trying to see if that implant looks too narrow or too wide on her. And that's what I'm taking into account. But there are multiple dimensions. There's projection, which is how far out an implant goes. There's CCs, which is just the overall volume. And there isn't technically a volume that's too small, but there is a breast width dimension. Like if it's too narrow for you, I don't want to put it in you because it's going to
Okay.
look off. So that's
Right.
really what we're trying to match up.
Right. So obviously that's very patient specific. And you as the
Yes.
surgeon are going to sit down with your patient and say, for your body, this is what we want to achieve and this is what that I can do and still achieve this result, I guess.
Yes. Yeah. And one of the big trends that I've noticed in the last, I'd say, year or two is that we are definitely trending towards smaller volumed implant. And I like that because I think when somebody is petite and they get too big of an implant, you have to always think about gravity and time and how that implant's going to age and functionality. I never want somebody's implant to make them look top heavy or bigger. You don't want someone's implants to make them look like a heavier person, and you don't want them to have functional pain from them. And you also want them to age nicely with the patient. And so for all of those reasons, volume is important. Like bigger is not always better. And I feel like finally we're kind of opening that chapter in breast implantation,
Oh,
which is
good.
very, I think, positive for women.
That brings up something interesting that I just thought about and I wanted to ask is probably, do you ever turn down patients for breast augs because they have unrealistic expectations? And I bring that up because I had a patient in Fort Lauderdale and it sticks in my mind. She wanted 1,000 cc implants and she was a very small framed woman. And the surgeon that I was working with a lot turned her down. So did the conservative surgeons that I worked with turned her down. But she did find somebody in Fort Lauderdale that did it. And then she came back to us infected and she almost died. And I mean, she sloughed a large part of her skin because they were too tight. And I just think, how do you deal with that with patients like that? I mean,
Yeah, thankfully, I think my patients are aware of my breast aesthetic just because kind of get a good read from that from before and after. I will say that South Florida has a little bit more of a way higher breast volume, but you also think about it, they don't see the long-term follow-ups with their patients. They're running them through and they're going back to wherever they live. So they don't really care about the long term if you're talking about like chop chops, et cetera. But for me, that is very important. And those patients will come back and see me. And so I want to make sure I do the right job for them. If you're going to give a patient a volume that's irresponsibly way bigger than their body can handle, you're going to have to violate anatomical structures that you cannot recreate. And so big one for us is going to be the inframammary fold. That is a very critical structure. And once somebody comes through that surgically or an implant comes through that, that's called bottoming out. And it's very difficult. It's going to be very expensive. You're going to need mesh. You're going to need another surgery to recreate that fold. So the fold in my eyes is sacred. If I have to put an implant in that's too big, that's gonna to violate that, I'm out. I'm not gonna do that.
So, John, I would say as first assistants, we need to understand when we're working with surgeons like Dr. Reddy, we do need to understand these potential complications and the outcomes that the surgeon is expecting and looking at in patients and all the things that you have to talk about with these patients. I mean, I think half of your
Exactly.
job is psychological. It's therapy for
Oh,
women. I
sure.
mean, it
Absolutely.
is. And a large part of your time in the office, I know, is spent talking and counseling, really, in a way. And as first assistants, we need to understand that. I like to ask my surgeons, like, what kind of outcomes do you see? What is their post-op time going to look like? How are these patients looking in the office? Ideally, I think it's great if we can work in the office and then go to surgery with you and do surgery, because then we have the full scope then of what's going on and how to better help you. And then we know exactly why it's so important, that so ticky sterile technique, and
Oh,
we're not
God,
rolling our
yes.
eyes in the operating room, because we know how important and critical it is that we keep that, like, I like your word sacred, that we keep that sterile technique so sacred. And so I think, rolling into that about, first assistants, like, what are some things, and ideally, do you have first assistants that work with you in the office? What does your setup look like where you are?
So I just told John, but my surgical volume reached a point where previously the surgical center I worked with, they provided a first assist, but the levels of talent were very variable. And so, I have admittedly some control and trust issues. And so if I don't know your ability to close, or if I can't sense it, you're not doing it. And my times were unpredictable, longer, shorter. And so that that amounted to enough frustration where I sat down and was like, I have to have one standardized control in every case. So I just have hired my own surgical SA who's going to be with me for all of my cases. And that has brought me so much relief. I was just talking to John before you got on about just having a trusted set of hands where you
Yeah.
know that they understand and respect tissue. Their sterile technique is going to be perfect. And one of the actual really nice things I was telling John is, like, sometimes as surgeons, we can look at somebody sitting up, but we're looking at it so surgically. And that's not who's judging the work. It's actually like a normal person who's looking in the mirror. And so sometimes my SA will point out stuff to me that she can notice as a woman that I haven't seen if I'm looking at it as a surgeon. And I trust her aesthetic eye a lot. And she has gotten a lot of practice from seeing patients being sat up and seeing what looks good, what doesn't. And so together we're a really good team. She brings me a lot of value, a lot of perspectives. But having somebody you trust in the OR, it takes so much weight off your shoulders. Like I told John, anytime I saw him in the OR, I was like, oh, thank God. Like, this day's going to go so much better.
See, I know we love to hear that, and
That's very
we talk
flattering. It
about that.
was.
Well, we talk about it a lot. I mean,
Sure.
that's what we aim for, and I have always appreciated the surgeon's perspective in that. And when you have trust, gosh, it's a lot of that you're, it's a lot of for us to that we can take for granted. A lot of the trust that you are having to have in us and our skill level and our knowledge. And so, yeah, that's a great. I mean, it's an ideal. What you have, that is an ideal, especially in your specialty. I feel like it's ideal for you
Yeah.
to have that. And I love hearing that you found someone and that you've got a good team going there. So great. That's great.
Yeah. And it's not I think about it all the time. It's a very difficult job to be an SA, and not all surgeons are like wonderful personality about it. But there is no stress like being in the OR, and you can go from casually chit chatting to all of a sudden
Yeah.
the level of severity can change very quickly. And the best SAs have always got a good pulse on that. Like John and me can be chit chatting, and then all of a sudden I'm like, okay, there's a bleeder. I need this, this, and this. And he can pivot quickly
Yes.
and know exactly, and always having a pulse on the environment of the OR. Those are going to be your best SAs who get it.
Yeah.
Again, saying just from my perspective, it was very flattering to be able to work with you because I came in as a traveler and I'm like, oh, it was personally meaningful for me that you put that much trust in me because I know the stresses that are involved in dealing with those patients. So for coming in as a traveler, I was over the moon that, that you put that much trust in me. And one thing it sounds bad to say, but I don't mean it that way. But I mean, for as young as you are exceedingly talented. I mean, you are one of the best plastic surgeons I've ever worked with, and I've worked with a few. And working with you was always a joy. I loved it. And to see your results now, I know you have a large social media presence, which I think is great. And you put your results online, and they are fantastic. I mean, I just think I think that community there is so lucky to have you.
I
And
appreciate that, John. That means a lot to me. As a younger female coming into a pretty established surgery community, definitely was intimidating. But at the end of the day, I do my best. I'll take as long as it takes in the OR. And I appreciate that my team around me has a lot of patience. Like they want to also do their best. So like no one's trying to get this case done as soon as possible. We want to do the best job. But I've been very blessed with people around me in the workplace like you who really supportive and
well,
been
thank
so
you.
kind.
Well, thank you very much. I mean, that's one reason Kelly and I wanted to do this podcast because we know I've seen it, and I know definitely you have because you spoke to it. The level of skill varies, and plus the level of commitment varies. Some people don't give a crap. They're there for a paycheck. 3 o'clock, I'm out. I'm not staying late. I don't care if you're not done. I'm leaving. Somebody's going to come in and relieve me, and they're just phoning it in. To people that are, and it runs the gamut. To people who are highly committed. They seek out extra training because they want to be better. They practice at home all the time, and I think that's what this job requires. And for the fact that it's really personally meaningful to me as well that you hired your own surgical assistant. I think that's fantastic because, a good surgical assistant can really, and you just spoke to that, can really, be a force multiplier. But
Absolutely. So it's a huge game changer. And I think we're very aware, like, as if you're an SA clinic out there, I think the ones who are practicing at home or committed, want to know, are enthusiastic, we're going to let you do way more than the ones who are trying to clock out. Those are, if my intent is go up immediately if I get that sense and you're not doing anything.
Oh, yeah. And just hearing you say
True.
that, I mean, it's important for our listeners, just hearing that from a surgeon's mouth, what is important. And you can tell how engaged we are and how concerned we are and how into what we're doing. And when I'm asking you questions about, what do you want me to do here? And I'm tuning in to what you're telling me. If I've walked in as a traveler, and I have, and had to go assist plastic surgeons, I get it. I get that you don't want to just throw caution to the wind and let me back there and start closing somebody. So, but knowing from that surgeon's perspective, what qualities, what are you looking for, and you can tell. And John and I say that your surgeon can tell if,
Yes.
what you are, how engaged you are and how interested you are in what you're doing. So, for our listeners, hearing you say that is very meaningful and helpful as well.
Yeah. Well, you guys are awesome. I'm happy to help anytime. And I think that's great that you guys are doing this podcast. I think that niche is going to be very appreciated because there's not a lot out there for them.
No, true. And I always have this in mind of the surgeon or the surgical assistant that's out there in the middle of nowhere working in isolation that maybe doesn't have access to bigger surgeries or, very accomplished surgeons like yourself and other people that we've worked with. I just had a couple more questions. How would you say that your practice breaks down? I know you said breast is a large part of it. I know you do a lot of mommy makeovers too, which you're getting phenomenal results from that.
Thank you. Yeah, so I'm one of the believers that facelifts have become so niche, and the deep plane facelift is truly, I think, the gold standard for facelifts these days. some of the older generations, they were doing a skin-only facelift, and that looked great on the table, but within 6 months, I'd say that your skin relaxes back, and you're not seeing a lot of those refreshments. So coming in the deep plane is a very high-risk plane because there are very important facial nerve structures there. But in the right hands, that's truly gonna give you a very rejuvenated look that's gonna last you several decades. And because that is such a specialized area, I'm not in that place in my career. My true passion is breast and body. So that's kind of
Mhm.
where I stay. I do upper eyelid blephs, and we're seeing a huge uptick in that, especially because I think this generation is on their FaceTime, Zoom, TikToks, Instagrams. They're seeing their faces so much more than older generations were used to. So I do upper blephs, and then I do breast body a lot. But I do think that the next chapter of facelifts will be dedicated to mainly facial surgeons, whether they're plastic surgery or ENT, is going to be trained in the deep plane of the face.
Oh, that's interesting.
Wonderful.
Hmm.
I know. I also wanted to bring it up because I know you and I have worked together doing those cases. That you also have a part of your practice that's transgender as well. You do a lot of the FTM, the female to male top surgeries, and
Yeah.
I think
And so, like as over politicized as that topic has been,
mm,
at the very foundations of plastic surgery, our goals are just to make sure that a person is comfortable in their body, that being in your body isn't a constant second thought. Because to imagine being in a body where you're constantly second thinking and it doesn't match your mind is actually incredibly fatiguing and very emotionally distressing. And so I do a lot of FTM surgery. I find it incredibly rewarding. I do think finding the right patient. So I screen all my patients. I make sure that they have a secondary mental health provider who can verify their diagnosis of gender dysphoria. But this has been several years in the making. I sit down with all of my patients and say, look, I don't have a good reversal surgery that can bring your breast back. So this is going to be permanent. There is no good detransition that's ever going to recreate the anatomy you have. So this is going to be a one and done. We can't go backward. And so I need me and you to be on the same page about this. And this has to be something you really, really know without a doubt that you want. And by the time they're in my consult room, they've gone through a lot of hurdles to get there. It's pretty intimidating to even finally make that step for a consultation. But doing like, a double incision mastectomy and, those are big surgeries and that anatomy isn't reversible. And so that's one of the things I always make sure to tell my patients. And I wish that the people who didn't understand it, if you could ever just be there in like a post-op clinic, and this is one thing
mm,
I wish for my essays too, is like
mm,
they work so hard with me in the ORs, they don't get to see that day where like the reveal where like the patient takes their bra off or their binder off and sees their new anatomy. And just that emotional transference is huge. That's what prevents
yeah.
so much of my burnout. And that's
Mhm.
one thing
Yeah.
I really wish I could share with a lot of my essays is like truly are changing people's lives in a huge
Right.
way. And you're a huge
Yeah.
part of that.
Exactly. I mean, and my personal beliefs of that have nothing to do with my performance as an SA. I'm there to do a job and do the best job I can do. But I do see it because those patients, every one of them that you and I have worked on together, they are so happy that day is finally there,
Yeah.
and to be able to
Yeah.
share that is really good. But, it also kind of, I mean, we're all people at the end of the day, and you have the right to do whatever you want to do, I guess. But to see other SAs refuse to do those kind of surgeries because they have some personal belief to me is just, we don't have that luxury as healthcare providers, I don't think, because we work on prisoners, but I think that, these life-changing surgeries like bariatric surgery, like these transgenders, they can make such a difference in people's lives, and I think it's got to be, a difficult position to be in, to have, that issue where you don't feel like you fit in the body you were born in,
Yeah.
so, I think that's what you're doing is wonderful. I think, and you get an excellent results. Are there any caveats you'd like to pass along for surgical assistance with that? Because I know the first time we did one together, you said you wanted me to defat the nipple, and I was like, "It's been a long time since I've done that. You wanna show me first so I can be sure?" I just didn't wanna hack away at it, and
Yeah, the free nipple graft, having an assay, you can kind of clean off the fatty part of that and leave you a nice thinner surface of dermis. So when we're placing a free nipple graft, the first couple days, that nipple is living off only brand new blood supply that's going to grow into it. So we don't want any kind of shear, and we don't want too thick of a nipple because then the blood supply won't be able to make it through. So we really have to clean that surface off well. And that's technique driven and very helpful. My essay is good at that. That's very helpful. And that's almost always while we're going to either put a bolster or like a negative pressure dressing on that nipple graft. Because if it is moving around even microscopically, it's going to shear all those blood supplies and die. And so that's why you really want to immobilize that nipple as well as we can. And, I have run into essays who don't politically agree with the surgery, so they feel like, I'm going to opt out. I've had that a couple times. I think when you take a bigger step out of it, it's just about, for me, a lot of this is not politics. It's just about kindness, sitting down with a patient. They're suffering. I'm going to try to help ease your suffering and in a non-judgmental way. I think it's as simple as that. I really do. And when you see those patients' lives truly change, it's a lot more easier to understand that surgery.
That's great. Thank you so much. I guess you've kind of mentioned it. Is there a way you can encapsulate, like, what do you look for in a surgical assistant, or what advice would you give to new surgical assistants out there that have an interest in plastic surgery and, want to make that their career? Maybe find an excellent surgeon like you and work with that surgeon.
I think the number one thing that you do look for is just like enthusiasm, just like what you mentioned, like asking questions when you're not sure. It just shows that you are concerned about that patient in your technique. But I'm always paying attention to an essay, and I appreciate when they ask me, hey, how do you like this closure, instead of just jumping in and doing what they're used to doing. Even the small things like how you tie a drain in. I like to put my anchor stitch below that drain, because if you put it above, that drain falls down. It's constantly pulling on that patient, and that patient's going to have pain for the next 5 to 7 days. So I've cut people's drain stitches out, and they're like, wow, she's really uptight and annoying. But truly, those tiny things matter a lot. Like, imagine being that patient. Every time you move for the next 5 days, you're going to have severe pain at that drain insertion site. If you can just change the orientation of your suture, that's going to make a huge difference. So small things that are not nitpicking, it comes from time and understanding a patient's experience. But I appreciate when essays just are enthusiastic, excited, and give me feedback like, hey, I'll ask the essay all the time, like, hey, what do you think? Do you think we should add some fat here? Because I appreciate that they have a human view of the breast that they can add to my perspective.
Yeah.
Wonderful. Thank you so much. Kelly, you have anything, any final questions you want to ask?
I
Or
can't think of anything. We really appreciate your time.
yeah,
We
we're so
really
grateful
do.
for you
And
to come on and share your expertise with us. I mean, it's fantastic.
Well,
Do
it's
you want to talk
awesome. It's so good to talk to you guys. And Kelly, I'd love to work with you one day. I know it sounds great. You are. I'm sure you are too.
Kelly's
Yeah,
very
I would love
good.
it.
Do you want to talk a little bit about your practice, like where you are and how patients get in touch with you?
Yeah, so my practice is Reddy Plastic Surgery. We are in Richmond, Virginia. I think the things that I have definitely prided myself on as we've built this practice is just we've kept a very boutique and intimate feel for all our patients. So I personally see all of my patients every single visit. I'm not going to outsource that to a mid-level. I find that plastic surgery, Kelly, I think you could touch on this a little bit. There is a huge emotional component that goes into changing your body, and I do want to pay that respect. So I spend a lot more time with my patients, and I know that they do go through a little bit of psychological stuff, and we go through that with them so that they never feel isolated. And I think that's a huge part of our field that we haven't used to talk about. Like the first 2 weeks after any kind of mind makeover, tummy tuck, anytime you change your body significantly, because of the anesthesia, because of the opioids, because you're being pulled out of your normal routine, there is a little bit of a blip of depression, almost like baby blues, that almost all of my patients go through. And in the past, I felt like women were kind of just like crying and doing that on their own and just not mentioning it to anybody. But now that I've recognized that, it's given me an ability to give them a heads up. You may cry in the first 14 days. And even though you've been waiting and saving for the surgery your whole life, you may feel a little sad those first 14 days, and that's totally okay. It's very normal. The break takes a little bit of time to adjust to a brand new body and what it's seeing in the mirror. And
So
that
interesting. Yeah.
takes patience and time. And I don't think surgeons were talking about that with their patients a few years ago, but now I think it's really important that we should, and that gives patients a much bigger emotional heads up. So we as a practice do try to focus on that stuff to make this as easy as a process as we can for our patients.
That's great.
Nice.
I love your social media presence too. You have some great stuff on Instagram. I always love seeing what you guys post because I can tell you guys have so much fun at what you're doing. You're serious in the OR and you're serious with your patients, but you just have the levity that I just love. But I know that you did a dual major in neuroscience and psychobiology. Is that correct? So
Yeah.
I think that the operating room itself, not to get a little too off field, but I think the operating room itself is like a container for alchemical transformation when it comes psychologically. When you think about it, a lot of those rituals are encoded in that process and procedure. You're giving up your identity. It's a ritual death. You're reborn, and then you're transforming your body into something new. I think plastic surgery is the perfect vehicle for personal transformation. People make those hard changes of putting in and doing the work and changing their body. And then the final step, if they've lost a lot of weight, is to get that surgery, or if they're having gender identity issues, to change their body so it feels more in line with the way they feel inside. I think there's no more. I think surgery in itself is a sacred profession, but I think plastic surgery is a completely transformative practice, and I love the way you approach it, and I think your patients are so lucky to have you, honestly. And I hate to keep saying it, but you're so young and so talented. You're just at the beginning of your career. I can't wait, just to see you in 10 years and how much better you're doing. How better your techniques get. And I think it's fantastic. So
I
I'm so
appreciate
glad you
that
were
so
able to
much.
join us.
Yeah, absolutely. Yeah, you said it perfectly. I think plastic surgery is the marriage of surgery and psychology, and like that's always been a huge interest for me. You have to appreciate both nuances to be a really good plastic surgeon, and you nailed it on the head for sure. And I think I have like the best job in the world, so I feel very grateful every day.
That's wonderful. Thank you so much,
Same.
Dr. Reddy. I appreciate it.
Absolutely.
Thank
Well,
you.
hopefully we'll do this again sometime soon. If you guys need anything, you let me know.
Thank you for joining us today. We invite you to like, comment, and subscribe to our podcast. Feel free to look us up on Facebook at The Surgical Assistant Podcast. If you like, you can also email us at thesurgicalassistantpodcast@gmail.com. We look forward to seeing you on the next episode. Content of this podcast is created for surgical assistants and is educational only. It is not intended to diagnose, treat, or offer medical advice on surgical conditions. No patient-specific information is shared, and all HIPAA guidelines will be adhered to.